our CDs, the higher, they're all in an order. The next one you choose is going to put more demands on you because you're going to have to inhibit more, you're going to have to integrate more, you're going to have to internally rotate more, you're going to have to isolate more, and here's the big one, you're going to have to inhale more, the 5 I's. But to start off with, we're going to do just a little bit of the first one. Isolate. Find it.
Would it also be assumed that with the manual would be to assist him to accomplish and then independently move into the non-manual?
Absolutely. In fact, if we can manually, if we can't get him non-manually, we're going to assist him manually, and then we're going to come back and non-manually. And we have this all written out. Here's what we would do following a manual technique. I love it. Do you think we picked that up on? Was that loud enough? Okay. Thank you. And when you ask your question, ask it as loud as you can. Okay. Yeah.
So, can we start with the standing one versus the one over there?
Sure, you can. What the standing was today, what the standing was to demonstrate how difficult it is for some people, Jonathan, and how easy it was for some of you who had no problem with that. The point of me doing it in standing was to say, are you aware of the left floor? Can you stay on your left side when you blow up that balloon? That's 1/2 of the gait cycle for your rib cage. 1/2 the gait cycle for your rib cage. Are you on the left floor? And so it's a great way to see if you can blow up a balloon and breathe in, expand, without doing this. Watch.
So if you can't do it standing, go to.
Oh, absolutely. And I would not, for a person for an athlete, and for someone like Jonathan, he probably could figure this out. But the kind of people we're talking about right now, they're kind of crawling into your clinic. They're kind of saying, you know, Doc, my back's killing me. They're going to have a tough time with that. Because the first thing they're going to do when they put that balloon in their mouth and they breathe in is what? Extend. And as soon as they extend and they start to go back on their heels, you're done. That's why you have those 5 techniques. On all those 5 techniques, Rick, every single one of those techniques has your back into what state? Cockroach. Remember the cockroach running around? Flexion. That help? Good question. Here we go. The left anterior interior chain manual technique that I'm about to demonstrate to you is the chief technique, or the #1 technique used by Posture Restoration Institute trained therapists to achieve expansion of the right apical chest wall, or the left posterior apical chest wall in the mediastinal area. It reflects the pattern an individual is in, and the pattern that an individual cannot get into as a result of having a limited ability to fully exhale on the left and fully inhale on the right. This technique is designed to move ribs down on the left side to help with the diaphragm's capability of achieving good respiratory mechanics for inhalation that should be occurring on the contralateral side in the right apical region. So it's a very important technique. It precedes all other left AIC orientated manual techniques. And it's a very important technique to use for all of our brachial chain manual techniques that will also be demonstrated in this video.
The operator is going to be at the head of the patient. Their left hand will be on the left body of their sternum. The tip of the operator's left third finger should be slightly below and around the xiphoid process. The operator is going to ask the patient to roll to their left. They're going to place the right hand underneath the patient's central right back with the most lordotic apex vertebrae between the third and fourth fingers. During inhalation, the operator is going to pull, guide, and rotate more with their right hand, right back of their arm and forearm. They're going to push and guide, rotate and hold the upper left chest with their left hand as they slightly pull the entire chest with their right hand. During exhalation, the operator is going to guide the left ribs down while they pull the right thoracic up. They're going to hold at pause phase of diaphragmatic breathing.
Now, this technique is an important technique from the standpoint that both hands have a purpose. The left hand is the hand that guides the air out of the chest wall, and the right hand is the hand that guides the air into the chest wall. My third and fourth index fingers, or my third and fourth fingers, are in the most lordotic position of the lumbar thoracic junction. They need to be below the T8 and T9 level, as that's the level that the diaphragm leaflet lays in. And so with that in mind, as you pull or guide the air in on the right side with your right hand, that position your hand is in should help reduce any lordotic curvature that is hyper excessive or is too great, and should also help reduce the extension of that lumbar thoracic curve, allowing the ribs in the front to move more down and caudally, which puts the diaphragm leaflet in a better mechanical ventilatory state for good respiratory mechanics. The left hand is used to help disengage the neck. It's used to help move the ribs down into an internal state, and it's primarily an exhalation hand. So on inhalation, my right hand is going to help guide air in, and on exhalation, my left hand is going to help guide air out. The one last thing I want to make sure I emphasize is that when she's in one state of respiration, whether it would be inhalation or exhalation, there is one active hand, and while the other hand is docile and isn't moving. So in this particular technique, my left hand would not be moving when my right hand is helping her get air in. Therefore, my left hand is serving as an opposition hand to the diaphragm leaflet on the left side. So now we'll demonstrate that technique. It's also important to remind yourself and the patient that you cannot do this over t-shirts or clothing that interferes with contact on the skin. Therefore, I have my hand directly on her spine, and I'm underneath her strap of her sports bra, so that I'm not treating the sports bra, I'm treating the trunk and the torso itself. She's going to take a deep breath of air in through her nose. She's going to exhale. I'm going to guide my left hand down with her chest wall mechanically moving towards the left hip. She'll pause. She breathes in. My right hand is helping her pull that air in with that left diaphragm. I'm taking her right ribs up in the back. She'll blow out. I'm guiding that left rib cage down again with my left hand. At the end of exhalation, she pauses. She breathes in, resetting that diaphragm leaflet. She blows out. And right there, you'll feel her ribs drop very, very easily in a state what we call zone of apposition. With that being said, as she breathes in now, I don't have to pull her ribs up on the right side. She just expanded her right apical chest wall, blow out, using her left leaflet, her left diaphragm leaflet, which is being opposed by my left hand at this time. I usually do this technique with 4 breaths in and 3 breaths out. So she takes a breath of air in, she blows out, she pauses, she breathes in, she blows out, she pauses, she breathes in again, she blows out, she pauses, and after that last breath in, you stop that particular manual process. If you haven't restored her zone of apposition by that 4th breath in, you need to let her rest a little bit and then attempt to do it again. The word is guide. You aren't pushing anything. We aren't doing any fascial release. We're guiding that ventilatory mechanical system to work neurologically as best as the patient will possibly be able to do.
All right, I'm going to have Jonathan come on over up here. Jonathan, you're going to lay down, take your shirt off. We're going to have you guys get up, stand around. We'll try to move this table that way a little bit. All of you get around as much as you possibly can. So let's go ahead and lay you back on your back. Lay back on your back.
I'm a bit. I am a bit.
And we're going to get you straight. Okay, and we're going to put your feet up here. Is that okay? Now, if you don't have this, you can probably still carry this activity out without this if the knees are bent. Pillows work fine, just a bunch of pillows under there. Okay, left hand is exhalation hand. Right hand is inhalation hand. Which hand do you think will tell you what the zone of apposition is doing? Boy, there's so many people behind me. Come on over here. Can I flip him? Would it be okay to flip him? No. Guys, come on over here. My left hand's going to tell me whether or not I've accomplished a good zone of apposition. Once I get that zone of apposition, I'll let you see, and you'll see what it looks like, okay? Right hand's going to be my hand that's going to really pull the spine into what? Flexion. Okay, so he's going to go to the left, turn to the left, bring your hand with you, and I'm going to find, can you go a little further to the left? I'm going to find the most apex-oriented part of his lumbar spine, which is, Jonathan, going to be, would you agree, right there?
Yeah.
That's probably L1. Okay? If he lays down and I feel like my armpit is in his face, I'll go to the next one or the next one. And Stephanie, if I was really small like you are, I may not do this technique at all, depending on the size of this patient. I've got another technique I'll show you tomorrow that I would do. So that's where I'm at. I'm going to stay standing a little bit at this point. My hand is cupped around his thoracic mediastinum posteriorly. Can you feel that palm right there?
Yeah.
My third and fourth finger, do you feel that? My third and fourth finger is on probably L1. Do you feel that, Jonathan?
Mm-hmm.
Jonathan, your only role here is to make sure you breathe and make sure you let everybody know if the operator is skimming over that transverse process, the vertebrae that I'm anchored onto right now. Don't let me slip. If I slip, I'm going to start over, okay? Take a breath of air in. Blow out all the air. Blow. Left hand's going down. Lay your head back. Pause. Breathe in. Okay, now I want you to help me with everybody, okay? Relax. Let's talk. Jonathan, when you breathed in, did you feel me pull my right hand up?
Yes.
When you blew out, did you feel me guide and direct this left rib cage down?
Yep.
In the direction towards your left front pocket.
Mm-hmm.
Correct?
Yeah.
So you take another breath of air in. I'm on his sternal notch. He blows. Did you feel the guidance?
Yes.
Pause. Breathe in. Did you feel me pull up on that thorax?
Mm-hmm.
Did you feel me slip yet?
Mm-mm.
Good, because I did not. Blow out. Would you say, I got it? Keep your head down. Take a breath in. Did you feel a pull again, Jonathan?
Mm-hmm.
Blow out. And I'm going to do one more on you, right here. Breathe in. Now, Jonathan, have I slipped on that spot yet?
Mm-mm.
Jonathan, I'm going to turn you to the left. I want people to see where you're at right now. Do you see how far my hand came up? It was way down here at one time. So, Susan, I didn't slip on him. Why do you suppose my hand went from here, Jonathan, to here? If I didn't slip on his spine, where did those 4 inches come from? Thank you. Distraction and flexion. That was what the whole day was about right there. Do you remember before lunch that picture of that individual that needed more flexion in a certain area and more extension in a certain area? I just gave that individual that activity. I extended where he needed extension and flexed where he needed flexion. Does that make sense? I took that low T8 area down here, or that low T12 area down here. What did I do to it? Flexed it. Kind of got it flexed a little bit. And then where did I get the extension? Where did the extension come from? Right above that area, he has to start to extend a little bit to keep that flexion going all the way up through the thorax. And you have that graph in your handout. That's the technique. I'm going to do it again. And then I'm going to let you all break, and we're going to practice it on each other. I'm going to do it again. He's going to go to the left. I'm going to put my hand back on, and now we're right here. And he doesn't even have a good apical not apical, a deep